In part 4 of Psychopharmacology 001, we're going to look at antipsychotics and mood stabilizers. I know I'm not following quite the order of the book by Preston and Johnson, but I think we need to understand antipsychotics before we can move into mood stabilizers. Antipsychotics are classified in several different ways. One way is typical antipsychotics, also known as first-generation antipsychotics, and then atypical antipsychotics, or second-generation. The first-generation typical antipsychotics began to be created or discovered in the 1950s, and they were considered like non-surgical lobotomies. If any of you have ever seen the movie One Flew Over the Cuckoo's Nest, you know that back in the 30s and 40s and early 50s, we did these horrible surgeries called lobotomies, trying to control some of the symptoms associated with schizophrenia. The first generation typical are used much less often today due to their side effect profile. Just as with the antidepressants, the tricyclics and the MAOIs are used less frequently today because of their side effect profile. The most common and still in use today of the first generation typical is haloperidol, followed by possibly chlorpromazine, thorazine, and then followed by flufenazine, thorazidazine, and ferfenazine. All of these you will occasionally still find clients who are on them. These first-generation typical antipsychotics are classified by the way they bind to D2 receptors throughout the brain. They are D2 blockers throughout the whole brain, and that's why we have the side effects that we do. And that's why we spent so much time looking at the dopamine pathways throughout the brain. So they bind to the D2 receptors either in a high, medium, or low potency. The higher the potency, the greater the incidence of dystonias, muscle disorders that we'll look at. The lower the potency, the higher the incidence of the anticholinergic dry mouth, dizziness, constipation. For many of our clients who unfortunately don't have insurance, we may need to put them on haloperidol. Starting in the 1980s, we developed the atypicals, or second-generation antipsychotics. They are only called atypicals because in addition to blocking dopamine receptors throughout the brain, there is a complex interaction of serotonin antagonism at the 5-HT2A and C receptors, and that affects the acetylcholine, GABA, glutamate, and dopamine presence in the brain. So they don't work like the first ones typically did, so they are called atypical. Better that they are called second generation. They treat both the positive and the negative symptoms of schizophrenia, the hallucinations and delusions, and supposedly they treat the negative symptoms as well of the cognitive blunting and the affective blunting. Again, supposedly they have less side effects. However, it's like jumping from the frying pan into the fire. They may not cause the dystonias and the anticholinergic problems that the typicals do, but they have caused a lot more metabolic problems of increased weight, increased blood sugars, hyperlipidemia, increased cholesterol. Now, on the right-hand column, you can see the list of these medications in their brand and generic and the year that they came on market. And as you can see, in the past year, there were 2 new medications introduced. Another way to classify the atypical second-generation antipsychotics is by the last parts of each of their names in the generic form. So they are the penes, the dones, and the 2 pips and a rip. And this is a classification by Stahl. The penes generally are more sedating and cause more weight gain than the other ways that the medications are classified. The first generation antipsychotics had a higher reputation for causing dystonias, which are muscle disorders, and pseudo-Parkinsonism, as you can see in this picture. There would be what was called torticollis, which is a stiffening and twisting of the neck. There was an ocular gyro colus, which is the eyeballs rolling upward into the head, so only the whites of the eyes are seen. There is another severe dystonia that we'll see in the next slide. And then pseudo-Parkinsonism, giving the shuffling gait and the pill rolling gestures of Parkinsonism. These are all caused because of a decrease of, by blocking the D2 receptors in the striatal area from the mesostriatal pathways, a lack of dopamine because the dopamine receptors are blocked. There is not enough dopamine. It can cause these movement muscle disorders. That's why if people are on a first generation antipsychotic, it is good to do a periodic AIMS, which is an assessment of involuntary movement, and you can find that online. It's just simply to watch a person's movement and to test the fluidity of their arm as they flex their elbow. The first generation also can cause tardive dyskinesia and akathisia. However, so can some of the second generation antipsychotics. So tardive dyskinesia can occur after someone has been on the meds for even a long time, and unfortunately, it can become permanent or irreversible. Now, to counteract or diminish the possibility of these dystonias taking place, usually if someone is on a first-generation antipsychotic, they may be also prescribed benztropine, which is an anticholinergic that will combat the effect. However, it is not necessary to always put someone on just as a matter of fact. It probably should be after some assessment has been done with an AIMS assessment. If, however, tardive dyskinesia occurs, using benztropine can actually worsen the condition. Now, akathisia is a feeling of restlessness, a feeling of pacing. It feels like anxiety, but it really is more of a physical restlessness caused by the cholinergic effects. So Abilify and Latuda, which are among two of the newer medications of the second generation, in fact, some would even call them third generation, they can cause a lot of akathisia. And when it manifests, it's usually more of a movement, a restlessness in the lower extremities with a tapping or a moving or a jitteriness, and it happens more during the day. And that would be the differential from restless leg syndrome, which happens at bedtime and during nighttime. However, when a person is already anxious, this akathisia can be hard to distinguish from the actual anxiety. The differential would be the time frame in relationship to the medications. And it can also happen if we are cross-titrating from one of the antipsychotics to another. The cross-titration can be a rather tricky balance, and I encourage you to look in the Stahl Prescriber's Guide for any of the antipsychotic medications. At the end of each medication description in Stahl, he usually gives a chart of how to cross-titrate the medications. Both first generation and second generation antipsychotics can have many different side effects beyond the dystonias. The first generation, especially because they're blocking dopamine in the prefrontal cortex, are decreasing the cognitive clarity, the cognitive sharpness, and schizophrenia in and of itself can cause that. And so unfortunately, the first generation medications can even worsen that. The first generation has a high incidence, especially if they're low potency binding to the dopamine receptors, high incidence of anticholinergic effects. There can be postural hypertension, changes in heart rate. Many of them do cause sedation, especially the penes, clozapine, quetiapine. They can also cause weight gain, and the two worst with increase in sugars and lipids, and the two worst in my experience, three in my experience, are Zyprexa olanzapine, Seroquel quetiapine, and Clozaril clozapine. It is risperidol primarily that causes the last two, and we've talked about these in other slides. This is that little dopamine pathway called the tuberoinfundibular pathway, and there on the right you can see a picture of a gentleman who has developed breast enlargement, which is gynecomastia. As was mentioned, the second generation or atypical medications is like jumping from the frying pan into the fire. And this chart gives a good comparison of the propensity for weight gain, dyslipidemia, and hyperglycemia. Two of the greatest offenders are clozapine and olanzapine, and yet recent articles are encouraging more frequent use of clozapine, especially in refractory treatment-resistant schizophrenia, rather than resorting to polypharmacy of several generations, several second generations at the same time, or second generation and first generations combined. Geodon or Zyprazidone now also has an FDA warning for a DRESS syndrome, DRESS, drug reaction with eosinophilia and systemic systems. There have only been 6 reported cases associated directly to Zyprazidone, which starts as a rash that can then spread all over the body, can be accompanied by fever and swollen lymph nodes and elevated eosinophils, and it can lead to death. There are no specific treatments, so it is best to have early detection and symptomatic treatment. I have in my practice had 1 case of DRESS. Latuda, which was approved in 2010 for schizophrenia and then in 2013 for bipolar depression, has reputed fewer metabolic effects. However, it can still cause high levels of akathisia and also sleepiness. It works primarily on the 5-HT, not primarily, in addition to working on the D2 receptors and the 5-HT2A and C receptors, it also works on the 5-HT7 receptors, which has a possible impact as being an antidepressant and improving the negative symptoms. Because of the high incidence of metabolic side effects from the antipsychotics, whether they are first or second generation, it is advised to monitor on a regular basis people taking especially the atypical antipsychotics. So this little chart gives a good idea of what to do and how often, and it's something that's good to keep on your desk somewhere so that you can refer to it. It is good to also try and keep track somehow in your charting when your clients have been monitored for these things. The guidelines are there, but how well they are followed in practice is quite varied, unfortunately. And some of the reasons are that we are pressed for time in 15-minute med checks, and so we may not even remember to do these things, or we do not have a laboratory associated with our agency, so it's harder to get clients to go to a separate lab, or a client doesn't follow through, the results don't get returned, they're not filed properly, all sorts of issues. But I encourage you, as starting out as new practitioners, make every effort to follow these monitoring guidelines. It is for the good and well-being of your client. Now, over the years, I have developed a binder in which I have the monitoring guidelines for antipsychotics, mood stabilizers, plus a lot of other facts and figures that I want at the ready. I will bring to one of our first classes in MSN 634 that binder, and I am willing to let it be copied. I also encourage you to develop your own binder, and throughout the 3 semesters we will be putting lots of good resources in the Moodle article folders. In addition to the monitoring that was just mentioned, when we speak of Clozaril or clozapine, this is an exception. Clozaril, clozapine can decrease or suppress the absolute neutrophil levels and lead to the possibility of fulminating infections. So for us to be able to prescribe the medication, we have to be in the Clozaril or clozapine registry, and the website is there. The absolute neutrophil count must be monitored, there must be weekly blood draws for the first 6 months, and that results must be given to both the provider and the pharmacy. The pharmacy cannot dispense the Clozaril to the client unless it has a blood draw report that is less than 7 days old. Then after 6 months, it moves to bi-weekly, every other week blood draws, or twice a month for the next 6 months, and then finally to monthly thereafter. So it is a rather difficult medication to manage when you've got a schizophrenic population that drops in and out of treatment quite often, and it is very hard for many of them to do follow-throughs. However, it is still one of the most effective medications. So it might be worth the effort if possible. The effective treatment of people living with psychotic spectrum disorders can be quite challenging because of the disease itself interfering, the lifestyle of people interfering. So injectable antipsychotics rather than oral medications might be a good way to go. The most frequently used injectable antipsychotic up until recently was haloperidol decanoate, which was administered at about 100 milligrams, and it's a once every 4-week. Since then, though, many of the companies manufacturing the second generation antipsychotics have come out with injectable forms as well, and they are listed here. They can be quite expensive. However, when you consider the cost of people relapsing into psychotic episodes and having to be hospitalized, and the difficulties in their personal lives, then possibly the cost is offset. So there are advantages and disadvantages to giving an injectable antipsychotic. One of the difficulties is in many clinics, there are not people who are actually trained to administer the injectables. So do we as advanced nurse practitioners who also are RNs administer these medications ourselves for our clients? These are questions that have to be answered at whatever clinic site you end up working. The dosing strength and the maintenance strength all vary depending upon which medication is being used, and if you're going to administer an injectable, it is always recommended that it first be tried with an oral medication just in case you can uncover any allergies that might be there to the medication, because once you give an injectable, you can't suck it back out. All of this information is available online. It's available in STAL. And so if in your clinical practicums as you're in school, there is the opportunity to use an injectable, please then go and get further information on it. A serious situation that can arise with medications that work upon the dopamine tracks throughout the brain, the dopaminergic systems, is neuroleptic malignant syndrome, NMS. It is characterized by a high fever, muscle rigidity, mental confusion that can go into stupor, delirium, and coma. And there is a high incidence of autonomic instability that can end up being fatal. This may look similar to serotonin syndrome that was mentioned earlier, where we are hot, stiff, and in a tiff. The difference here is that we would be hot, stiff, and out of it. People with neuroleptic malignant syndrome often end up in emergency rooms. They do need possibly to be hospitalized in order to monitor and treat the symptoms of the autonomic instability, the high fever, the cardiac changes, and respiratory changes. There is an antidote, which is dantrolene, that would be administered in the emergency rooms. That is an anticholinergic, and bromocriptine is another possible antidote. Again, in outpatient practice, we probably would not be treating this, but it is good to know. This little table that I pulled off of some resource somewhere gives a quick glance of the distinctions between serotonin syndrome, neuroleptic malignant syndrome, and anticholinergic delirium. Those of us who are going to be working in hospital settings and as psych nurse practitioners in an emergency room department, we definitely want to understand the differential diagnoses of these three syndromes. Just as there was a major study, the STAR-D study for antidepressants, looking at the efficacy and side effects of those medications, back in 2001 to 2004, there was a major study of the antipsychotics, the CATIE study, Clinical Antipsychotic Trials of Intervention Effectiveness, that involved 57 different sites with 3 phases, and they showed that the first generation and second generations may be equally effective, just as they showed with the antidepressants in the STAR-D study. It is the side effect profile and the cost of these medications that is very disseparate. According to the study, clozaril may actually be the most efficacious medication, but because clozaril can cause a severe repression of the neutrophils and expose a person to fulminating infection, it is not used as a first-line option. In terms of tolerability, Zyprexa and risperidol had high ratings, but Zyprexa olanzapine also has a very high propensity for weight gain. The study did not include Abilify, and it did not include any of the first-generation antipsychotics. We move now to another clan of medications, the mood stabilizers, that are used primarily for treatment of bipolar disorder. However, I wanted to treat the antipsychotics first because many of the second generation antipsychotics have now also been approved as mood stabilizers. And this is again a reason why we treat symptoms and not diagnoses, because when you prescribe a medication such as quetiapine to manage someone's bipolar disorder, and they read the information on the handouts and find out that it's an antipsychotic, they may be highly incensed. So a lot of good teaching is necessary to explain why we are using these types of medications. Now, the mood stabilizers were initially used as anticonvulsants or antiepileptics, and this too can be very disturbing to people. And you're prescribing for them Depakote, and they say, but I don't have seizures, I'm not an epileptic. These medications are not very easily tolerated. Several of them have rather harsh side effects. Several of them have to be monitored. We'll look at that. So the mood stabilizers are lithium, which stands pretty much in a class of its own, and then valproic acid, Depakote, lamotrigine, Lamictal, and then off-label are for treating bipolar disorder are carbamazepine, oxcarbazepine, gabapentin, and topiramate. Lithium must be used cautiously in women who are pregnant because of the Epstein cardiac anomaly, and women who are of childbearing years. There should be great caution with Depakote because it can lead to spinal bifida. Lamotrigine and carbamazepine lead to that horrible rash called Stevens-Johnson syndrome, which can be potentially fatal. Carbamazepine can also cause other blood problems such as pancytopenia or hyponatremia, and so can Depakote. It can cause liver problems and it can cause thrombocytopenia. So lots of difficulties with these medications for controlling bipolar disorder, and these are people who already have a lot of difficulty with the great roller coasters of their moods and not wanting to have to put up with the harsh side effects of these medications. Just as there are monitoring guidelines for the antipsychotics, so we also have some very clear guidelines for bipolar medication management. We'll be discussing bipolar disorder in MSN 635. Lithium, which is still the gold standard treatment for bipolar disorder, especially bipolar 1 with mania, needs labs both before starting and needs labs for monitoring. So if you look at this slide, you'll see that there are 2 asterisks and 2 hashtags. Asterisks mean that there need to be labs before starting, and hashtags means there need to be labs while taking the med. Rather than trying to explain all of this right now, I advise you please just check the guidelines that are readily available in Stahl and in many other sources and places. The mood stabilizers, the AKA anticonvulsants or antiepileptics, Depakote needs both pre-screening and ongoing monitoring. Lamotrigine does not need any, except maybe to make sure that a woman is not pregnant and that they've not had a history of any type of rashes. And according to one of the most recent books I read, Managing the Bipolar Spectrum, lamotrigine is really a very good medication for people who have more of the lower end of the bipolar spectrum, more like bipolar 2 or less. Carbamazepine and oxcarbazepine are also mood stabilizers. Carbamazepine does need to have both pre and ongoing monitoring. As I mentioned, the antipsychotics are now also used for treating bipolar spectrum, and quetiapine, Seroquel with lamotrigine are the 2 most highly recommended combo medications put together. And because of the quetiapine then causing the metabolic effects, it is good to have the monitoring that we talked about earlier. As we start out, I do want to make special mention of the need to monitor lithium because, as we talked about, it is excreted by the kidneys. It does reach a steady state in the blood in about 1 week. However, it has a very narrow therapeutic range. Depending upon the resources you read, they'll be slightly different, but in order to treat acute mania, we need the level of lithium to be at 0.6 to 1.2 milliequivalents to maintain people balanced who have been living with bipolar disorder, 0.8 to 1.0 milliequivalents. But look at this, at about 1.5 milliequivalents, it begins to be toxic, and at 2.0 milliequivalents, it can be potentially lethal. We will be covering all of this again in 635, but I want you to know that these lithium levels were actually part of my American Nurses Credentialing exam after I finished my course of studies. Using lithium, then, we need to monitor very closely. A blood level must be monitored about 5 days after starting because it takes 5 to 6 days to reach a steady state, and the lithium level needs to be drawn at what's called the trough, 12 hours from the last dose taken. Depending upon the formulation of lithium you use, it can be a twice-a-day or a once-a-day medication. If it is a twice-a-day medication, then they come in to have their lab drawn in the morning, about 12 hours after their evening dose and before they take their early morning dose or their morning dose. To monitor lithium, maybe it should be done twice a week while starting until you see that things are leveling out and they're getting to be a pretty consistent. So maybe for a couple of weeks, once or twice a week, and then finally monthly for another 2 or 3 months, and finally every 3 to 4 months thereafter. Need to be very careful in hot weather, people who are very sports involved, or if they become illness with vomiting and diarrhea. All of these can cause quite an altering in the level of lithium. And unfortunately, lithium does cause weight gain and increased thirst and increased urination and even fine muscle tremors at a therapeutic dose. So a lot of education is needed if we're going to be using lithium, which still is a gold standard. It is the first line of treatment, but a lot of monitoring and education is necessary. And again, I remind you that with lithium, we need to be careful. Do not use NSAIDs, do not use ACE inhibitors, do not use angiotensin receptor blockers. Also, there is some interaction between lithium and birth control. This slide and the next give a quick chart view of the monitoring that needs to be done, the screening that should be done before a person starts taking these medications, and then possibly ongoing, or definitely ongoing at certain intervals. So with lithium, a complete blood count, a renal function, complete metabolic panel that gives you the BUN and creatinine, TSH, because lithium can affect the thyroid. Definitely make sure that the woman is not pregnant. Possibly, depending upon if there has been a history of cardiac problems in the client, to do a preliminary EKG, and then make sure that we're screening out for any renal disease, any congestive heart failure or arrhythmias, and make sure that they are not using the medications that can increase the levels of lithium. For valproic acid, also want to do a CBC with differential, because valproic acid Depakote can cause thrombocytopenia. Depakote can be toxic to the liver, so you want to do a liver function panel. It can also cause problems in the pancreas, so some resources recommend you doing a serum amylase, and also you want to make sure that the woman is not pregnant, because birth defect of spinal bifida. Lamotrigine, as I mentioned earlier, does not require hardly any monitoring at all, except to be monitoring for the possibility of rashes that usually would come out in the first week to 3 weeks of starting the medication. And because none of these medications have been tried in pregnant women, and because they can cause birth defects, you want to make sure that you have done a serum pregnancy test. I know this slide is hard to see. It's very small print, and I apologize for it. All of this information is available elsewhere, but this was the easiest one I could grab for putting together this slide presentation for you. I do have several wonderful books on my bookshelf, and one of them is called Managing the Side Effects of Psychotropic Medications by Goldberg, that really does give a fine treatment of almost any side effect that our medications can cause and how to manage them. However, since you're just starting out, you don't need to be having a library shelf that is quite, or bookcase, or a wall that is quite as filled up as mine, and I will be sharing these resources with you throughout the course. This will be the last slide in this portion of our peek at all those pills used for psychotic spectrum and bipolar disorder spectrum. This one shows again the need to monitor valproic acid when it's being used for the treatment of bipolar disorder. You can see there the liver function, the serum amylase, the CBC with platelets, and pancreatitis. One other side effect that I did not mention is that Depakote has the unfortunate tendency to cause hair loss in about 20 to 30% of people who use it, and also quite a bit of weight gain. I took care of one client who came to me after being treated for over a year with another provider, and she had been on Depakote all that time. She had gained over 100 pounds in the course of a year, and the other provider had not done anything to manage this and had not even explained it to her. And she asked me if could it possibly have been the Depakote. So again, I make the great plea that we be aware of the mechanisms of these medications, what the desired effect is, and what some of the major side effects are. And we are educating our clients so that they are well prepared if some of these things happen, and we are well prepared to manage the side effects. I don't expect you to know all of this as you come into the first day of MSN 634 on January 21st, but we do expect that by the end of your 3 semesters with us in that wonderful time of May of 2018, you will have achieved quite a bit of knowledge and comfort with all of this, but you will still continue to learn every day throughout your career, or at least that's what's happening with me.